So good afternoon or good morning, everyone, depending on your time zone, and welcome to the first session of the Knowledge Exchange webinar series, Bridging Health Systems, organized by the Egypt Impact Lab under JPAL-MENA in collaboration with the Universal Health Insurance Authority and the WHO in Egypt. Before we begin, I'd like to inform you with a few housekeeping notes. Firstly, please note that this webinar is being recorded and the recording will be shared with all the participants after the webinar. Also, this webinar is being held in English with live interpretation available in Arabic. You can select your preferred language from the interpretation icon on your Zoom toolbar, and you will find all the details shared on the screen. Also, the session will run for approximately from 90 to 120 minutes. And finally, feel free to drop your questions in the Q&A box throughout the session, and we will address them during the open discussion segment. Now, I'm pleased to hand it over to Dr. Riham, the Egypt Impact Lab Director, who will be moderating the session until we reach the open discussion. Here you go, Dr. Riham.
Thank you, Arwa. It is a pleasure to welcome you all to this important session on benefit package design, which lies at the heart of the Egypt health financing reform. Egypt Universal Health Insurance System was introduced in response to persistent challenges, starting from high out-of-pocket spending, unequal access, and long-term financial sustainability. Through our work with Universal Health Insurance, we at JPAL-MENA and the Egypt Impact Lab are committed to informing health policy with evidence, from evaluations to practical tools that support system-wide reform. This webinar series is a part of our broader agenda to strengthen the knowledge ecosystem and foster meaningful policy dialogue between Egypt and peer countries who have advanced universal health coverage. Today's session brings a rich blend of experience. From Chile, we are honored to be joined by His Excellency, Dr. Emilio Santelices, the former Minister of Health, who will walk us through a practical guide to benefit package reform. From Egypt, we will hear from Ms. Maya Farid, the CEO of the Universal Health Insurance Authority, and Dr. Ahmed Siom, the Deputy CEO for Technical Affairs at the Universal Health Insurance, who will share their policy vision, challenges, and opportunities for benefit package development. And from the WHO, we are grateful to have with us Dr. Naama Saeed Abid, the WHO representative in Egypt, Dr. Matthew Jawed, the unit head for health financing, and Dr. Ahmed Khalifa, the health economist at the WHO Egypt, who has supported the series from the outset and will lead today's open discussion. I would like to also thank our colleague, Maria Baz. Maria, she is our colleague from the Latin America office, who helps us to secure the communication with Dr. Santelices and help us actually to make this connection and to launch our first webinar series. And now, officially, I'm going to start the session, and I'm pleased to invite our distinguished speakers to deliver the brief welcoming remarks. I'm going to start with my colleague, Dr. Ahmed Sayed. He is the Executive Director of JPAL-MENA. Ahmed, the floor is yours.
Thank you, Riham. Good afternoon, esteemed colleagues and partners. It's a pleasure to welcome you all to the first session of the Knowledge Exchange webinar series, Bridging Health Systems, focused today on benefit package design. As Riham said, I'm Ahmed Sayed, the Executive Director of JPAL-MENA. I'm also an Associate Professor of Economics at the American University in Cairo. JPAL, or Abdul Latif Jameel Poverty Action Lab, is a global research center working to reduce poverty by ensuring that policy is informed by scientific evidence. We conduct randomized evaluations, synthesize global insights, and partner with governments to co-design and scale effective public policies and programs. This webinar series marks a milestone in our collaboration with the Universal Health Insurance Authority, UHIA, and the World Health Organization, WHO, in Egypt, and is led through our flagship initiative, the Egypt Impact Lab. The Egypt Impact Lab is a partnership between JPAL-MENA and the Ministry of Planning, Economic Development, and International Cooperation, It's designed to work hand in hand with government partners to generate and apply rigorous evidence to improve the effectiveness of public policy. This series contributes directly to a pillar of Egypt Impact Lab's strategic framework, which focuses on strengthening the knowledge ecosystem and supporting how government institutions access, absorb, and apply knowledge to inform decisions. This initiative goes beyond knowledge sharing. It's about building a platform for structured, peer-to-peer dialogue between government institutions where real-world implementation challenges are explored, policy tools are exchanged, and global lessons are adapted to local contexts. Today's session, in particular, addresses a core component of universal health coverage, how to design benefit packages that are equitable, efficient, and financially sustainable. These are not just technical design questions, but decisions that touch on inclusion, prioritization, and long-term health outcomes. Globally, our network of JPAL has conducted more than 250 randomized evaluations in the health sector, addressing issues such as primary care, maternal and child health, provider performance, and health financing. These studies do not merely generate academic knowledge, they also provide actionable insights into what works to improve health outcomes for whom and under what conditions. We are honored to be joined today by a distinguished lineup of speakers. I would like to sincerely thank our keynote speakers for opening today's dialogue. Dr. Naama Saeed Abeid, WHO representative in Egypt, Ms. May Farid, CEO of the Universal Health Insurance Authority. And I would also like to thank our technical speakers and contributors, His Excellency, Dr. Emilio Santlices, former Minister of Health of Chile, who will be sharing lessons from Chile's experience in benefit package design, Dr. Ahmed Siyam, the Deputy CEO for Technical Affairs at UHIA, who will be presenting Egypt's current priorities and reform efforts, Dr. Matthew Jowett, Unit Head of Health Financing at WHO, who has provided a recorded intervention offering a global policy perspective, Dr. Ahmed Khalifa, health economist at WHO in Egypt, who will moderate the open discussion segment. And a special thanks to my colleague, Dr. Hamriz, the Director of Egypt Impact Lab, and the team of JPAL MENA and Egypt Impact Lab for co-organizing this knowledge sharing series and helping facilitate this important policy dialogue. Your contribution all has been instrumental and is instrumental in turning this webinar into a meaningful learning opportunity for all participants. I would also like to recognize our colleagues and partners who have made this series possible, particularly UHIA and WHO Egypt. Thank you for your continued trust and collaboration. We look forward to the knowledge that will be generated through this lesson, to translating it into practical tools and insights that support Egypt's health reform agenda. Thank you once again for your presence and participation.
Thank you, Dr. Ahmed. Next, I'm going to invite Dr. Naama Saeed Abeid, the WHO representative in Egypt, to share his opening reflections. Dr. Naama, the floor is yours.
Thank you very much. And good morning, good afternoon, and welcome to this first session of our Knowledge Exchange webinar series, Bridging Health Systems. I am proud of this collaborative work with Egypt Impact Lab and the Universal Health Insurance Authority on the Knowledge Exchange webinar series on Bridging Health System. And it's a great pleasure to have you all online today as we embark on this journey of sharing experiences and best practices to strengthen health system in Egypt. As we all know, designing an effective benefit package is fundamental to ensuring equitable access to healthcare services and optimizing health outcomes. It requires a careful balance of financial sustainability, inclusivity, and responsiveness to the needs of the population. Of course, we are very much privileged to have distinguished speaker today with us and bringing a wealth of experience. In particular, His Excellency Emilio, the former Minister of Chile, because of the, apart from maybe population size, many similarities between Egypt and Chile when it comes to the health system, as both countries have started some kinds of health insurance decades back and evolved over time through several reform processes, and both having a mixed health service delivery systems with vertical system like the one of armed forces and others. And to me, the most important is the almost similar principles of universal access with explicit guarantees in Chile, with the universal health insurance coverage in Egypt. It's really interesting. And to me, maybe one of the key messages that we are getting to have the health insurance for expats in Chile, because as we know that Egypt is hosting more than 9 million refugees and migrants. I am also very much grateful to Matthew, who is WH expert in health finances. And Matthew, really, I cannot thank you enough for enjoying your holiday with us, your annual leave with us. I know that you are on leave, but really thank you so much for being with us. And thanks to Ahmed Siam and my dear colleague, Ahmed Khalifa. Together, we can learn from each other and work toward building stronger, more resilient health system. I look forward to a productive and enlightening discussion for this webinar and for the whole series in the upcoming months. And really, I would like to repeat what my colleague has said. We need this is not just knowledge sharing, but we need to build on the outcomes of this discussion and guidance and recommendation. Thank you very much.
Thank you, Dr. Naama. Finally, I'm honored to welcome Mrs. Maya Farid, the CEO of the UHIA, for her opening remarks. And I want to seize the opportunity to thank her being with us despite her busy schedule. Thank you. The floor is yours, Ms. Maya.
Thank you very much. And it's truly an honor to be with you here today and to open this important series that has come to life through the collaboration between Egypt's Impact Lab and the Universal Health Insurance Authority, the World Health Organization, and also all of our valued partners. Today, we speak about one of the most important commitments that we can make. It's not just for health professionals, but for global community. This is a commitment to universal health coverage where everyone and everywhere has access to essential healthcare services without financial hardship. At the core of this vision lies a powerful truth. Health is not a privilege, it's a right. And to make this right a reality, we must focus on three fundamental questions. Who is covered, what services are included, and how much of the cost is protected through pooled funds. These are not just policy questions, these are moral imperatives, questions that shape whether our systems are just inclusive and responsive to all the needs for all the people or not. One of the most powerful tools we have to address these questions is to design the essential benefit packages. But let me here be clear, it's not just a technical checklist of services, it's a reflection for our national values and the commitment to equity, fairness, and accountability as well. So how do we design the benefit package that truly delivers on this promise? First, the process of impartial and universal, ensuring that no one is left behind, especially for the most vulnerable. Also, second, it's that it must be inclusive and democratic, engaging communities in meaningful dialogues, especially for those whose voices are too often unheard. Third, it's just that it needs to be anchored in clear criteria, informed by robust evidence and national values, and adapted new data and realities emerge. We must also recognize the distinct roles of data, dialogues, and decision-making. Each of one of them has a purpose, and sometimes we confuse them with risk of policy to be reactive more than to be strategic. And crucially, our benefit design must be supported by sustainable financing and effective service delivery mechanisms. It's not just a promise for care. We must ensure that it can be accessed equitably and efficiently and with quality. In systems with multiple programs or schemes, each of different benefits and financing rules, we must strive for coherence and transparency. This means minimizing duplications, eliminating inefficiencies, and building a system that works as one, not as patchwork or disconnected parts. Also, uncertainty is always the enemy for access. So when people don't know what they are entitled to or how to get it, they delay care or avoid it altogether. That's why clarity is key. Entitlements also should be well defined, especially for first contact care. If co-payments are necessary, they should be fixed, predictable, and low, so no one can be forced or should be forced to choose between health or hardship. Finally, benefit design must align seamlessly with health financing policies. Budgets should explicitly support priority services, and provider payment mechanisms should reward efficiency, quality, and the delivery of care wherever they are needed. In closing, let me say that the benefit design is more than policy. It's a bridge between the vision and reality. It connects our ambition for universal health coverage to be a lived experience for every person who walks through the doors of a clinic or a hospital. When done right, it builds a system that's not only equitable or sustainable, but truly universal, where people can trust, engage, and access the health systems. Before closing, I would like to express my deepest appreciation for our partners, of course, and our distinguished speakers today, and to all the experts who have contributed to making this initiative possible, and of course to each of you, whether joining us from Egypt or abroad. Thank you very much for your presence, your commitment, and your shared dedication for building better health systems. We look forward for a productive and inspiring session today, and to be the continued collaboration throughout the Knowledge Exchange series. Thank you very much.
Thank you, Mrs. May. Always your contribution is really very insightful and opens several questions to the floor. Now the transition gonna be, thank you for the setting the stage for today's exchange. Let us now dive into the technical part of the session. And I'm going to give the floor to Dr. Matthew Jouait, the unit head of health financing at the World Health Organization. And he has kindly shared a recorded presentation with us, focusing on the policy foundations of benefit package design. And later on, Dr. Khalifa will be in charge of answering the question that is related to Matthew's presentation. Arwa, could you please share the presentation? Play the video, please.
Hello to everybody. I'm really pleased to join you in order to make this presentation. I'm really sorry I couldn't be here live for this Learning from Global Practices webinar. My name is Matthew Jouait. I'm the Unit Head Health Financing Policy, WHO in Geneva. Okay, I'm going to run through this presentation, and Ahmed in the room, I'm sure, will be able to field many of the questions. I may be able to make contact online through WhatsApp, or I'm actually going to be away from the office. Otherwise, I'd be very happy to follow up with any questions afterwards when I'm back. Thanks a lot. This is just a quick overview of the main topics. I have 15 to 20 minutes. A few initial thinkings. I would like you all to think about benefit design, and I'll come back to why we use those words rather than benefit package design, to think about it a little bit differently. So I open with that, and then we run through some of the choices you have, which can be around benefit design, which can be pro UHC, some uncomfortable truths, I think some challenging questions, which will be really helpful to tease out some of the details, and then just finish off with some key messages. So the first point is that benefits and rationing decisions are inseparable. The word rationing is not, I say, politically always that acceptable, but for our technical discussions, I think it's very clear. It's about limiting or excluding benefits. So just to be very clear up front, decisions about what to include, and when we say that in a benefit package, when we say that, we mean what to publicly fund, be that either fully or partially, in doing that, about what is included, you are either explicitly or implicitly making a decision about what not to include or what not to publicly fund. There's clearly a little Venn diagram here. There are some services that will be fully publicly funded, some which get zero public funding, pure private market. And then you have this group in the middle where there is some partial public funding and partial private funding. Unfortunately, my video is covering a little bit of the text at the bottom there, but when we say partial private funding, essentially means cost sharing, some kind of direct payment by the patient. Hidden there, it says user charge or co-payment. So here's where I want you to think a little bit differently, and we're starting at the top left here. This is how we think of benefit design from a health financing perspective. So first up, we're talking about a set of publicly funded entitlements. In ministries of health, governments, they have to think about how all government funding is spent. Okay, so in the small text in the brackets on the top left, so we're not only talking about benefit packages under insurance schemes, we are talking about those under mandatory, publicly funded insurance schemes, but we're talking about all publicly funded services. So if there's a lot of supply side funding, which also runs separately than through the insurance, in-kind products or budgetary flows, we really need to think of those. And I'm not sure the case in Egypt or other countries in the region, but what we see in many countries which sort of have what we think of as substantial health insurance schemes, actually what we see is there's far more money running through the budget. So we need to take that holistic point of view. The second key thing, a little bit different, I want you to think about is on the top right there, is benefit design is not just about what's included, but it's about the set of conditions or rules which govern access to these entitlements, conditions of access, we often think of them. And they might relate to only being able to access benefits in a particular type of facility, or having to follow a referral system, maybe having to make some patient user charges, maybe only obtaining generic medicines through the publicly funded, and if you want branded ones, you might have to pay extra, those sorts of conditions of access. So going to that bottom box, quick summary, benefit design is more than just a list of health service entitlements. It includes complementary policies in health financing beyond. It includes not just explicit benefit packages, for example, in health insurance schemes, but the totality of publicly funded services. And, those two sets of decisions, what to include and conditions of access, can be quite a powerful way to leverage change throughout the health system in terms of how services are supplied and by who and how they're demanded or consumed. So let's talk a little bit about navigating the difficult decision-making process, particularly about what to include, but also those conditions of access. This slide summarizes the process from Thailand, that's the Thai flag at the top left, and it outlines a very systematic process starting at the top there for navigating, quite complex decision-making process, a wide range of views and sets of information. So at the top, 7 groups: policymakers, academia, professionals, patient groups, CSOs, industry, general population. Actually, I checked in with Thailand recently, and apparently this is now 9 groups. Twice a year, they can make a submission about an inclusion in a benefit package. It can either be online or through some public hearings. As we drop down to the next box, there's then a stakeholder working group which selects from those submissions a set of topics using the criteria on the top right there. This is where it gets quite detailed and really important that you're bringing an agreed set of information, magnitude and severity of the condition that's perhaps being proposed. Are there effective interventions to treat said condition? Variations in practice around the country. This is an equity perspective in Thailand. They won't roll out a new benefit unless they know it can be delivered equally to all citizens across the country. Is this a disease that's having a big financial impact, or condition having a big financial impact on households, etc., etc.? So some topic selection using those very clear criteria. Then next down, kick it to researchers to do much more detailed assessment on the selected topics. This is the yellow box here: cost effectiveness analysis, budget, what's the impact on budgets, is it affordable, are there equity considerations, and again, is that supply side readiness there? And just quickly running through a subcommittee, we'll do some appraisals, maybe kick it back to the researchers, and ultimately goes back to the board. Actually, I didn't mention at the beginning, this is just for the universal coverage scheme in Thailand, which is now the sort of the largest one in terms of population coverage, for sure. Just to mention, also to mention on that, on the board of the UC scheme, there are civil society representation, patients groups, and so on. That's an important thing to remember as well. What I've just put on the top right there, values matter, and they will influence. You know, there's trade-offs running throughout this. Values matter. Does efficiency trump equity? Sometimes there are clear trade-offs. Is budgetary impact is always going to be of great import? And, you know, the balance between those trade-offs will change over time as more information comes in, as public gets more engaged, and so on. So a really nice example of a very systematic process. We see more and more countries trying to establish and institutionalize such processes, in a sense to limit, not to completely remove the politics, but to make sure there's as much evidence coming into the process as possible. Okay, let's move to the next section about how benefit policies can steer health systems towards UHC. Now, in terms of using choices and benefit design policy, so what's included, conditions of access to further our objectives and goals. There's quite a lot on this slide, so I'm going to go quite quickly. Equity in use of services is something we need to think about when we're making those choices. So we have systems where there are multiple schemes, maybe with different benefits for different population groups. I know that's not the direction of travel or the situation in Egypt, but I think it's worth thinking this through. It might be the case in other countries in the region. But in those, there's a big agenda. In fact, Thailand, that has been very much the case of equalizing or harmonizing entitlements across different schemes. For those in the scheme and for those that are not in a said scheme. So that equity dimension coming through quite quickly there. There's a couple of other issues I won't go into right now, but happy to follow up. Financial protection. I mean, these two boxes here represent UHC, our two sort of current measures or indicators of UHC, service use and financial protection. Again, are we including services which we know, or products which we know are driving catastrophic spending or impoverishment, right? And that should inform our decisions there. What we do know is that in addition to high cost but low volume or low frequency health problems, you know, perhaps a road traffic accident or a rare disease or a tumor or a cancer, certain types of cancers, these are rare, relatively low volume, maybe increasing, but relatively low volume and high cost. But what we also know is a big growth in NCDs and chronic conditions means that actually maybe the treatment is low cost, but the volume is very high. So we need to understand the epidemiological patterns in every country and make sure that the benefits we're including are really addressing these concerns. This is how you drive progress towards UHC. On efficiency, right, I mean, focus spending on cost-effective interventions for whatever conditions are included, you know, and by the same token, reduce spending on clinically ineffective or cost-ineffective services, and also only pay for services to be delivered in the appropriate level of care. So, you know, primary care, conditions that can be treated at the primary care, the purchaser, especially if you've got a strategic purchaser, insurance agency, you know, only pay for primary care sensitive conditions to be treated in a primary care setting. If a hospital does it, I'm oversimplifying a little bit, but you get the point. It'd be much more expensive to deliver said care in an inpatient setting. So the purchaser really needs to think about that to ensure value for money. On transparency, this is a really important one. Understanding the population clearly understands both their entitlements and their obligations, and also service providers is really important. It's about removing uncertainty over entitlements and conditions of access, in particular any payments that have to be made. Uncertainty itself creates a barrier for care and opens opportunities for people to actually maybe end up paying a lot more out of pocket than they should be. So let me say a few words about Chile, which I know is also featured in your series. So hopefully I'm not contradicting the messages from there, and you'll obviously be getting much more information. I just have one slide, but it's an example of harmonizing entitlements driven by this equity concern. What we see in many countries just before coming to Chile is that when you have multiple health coverage schemes for different population groups, and where the schemes have different benefit entitlements, indeed different conditions of access, you're effectively designing inequity into the health system. So if we look at Chile, the challenge there, and this is obviously going back 20 years, slightly more, was that there was the National Health Fund, FONASA, which covered but poor and non-poor. But then you have ISAPRES, basically private insurers, multiple ones of those, really target higher income households. So some quite difference in terms of the generosity, the quality of the benefits, and to some extent kind of a two-tier, quite a concern over the difference in or the inequities running through the system. And there was no legally defined benefit package at that point, so very significant differences in coverage between the schemes and benefits. What Chile did was it introduced in 2005 this UHIA scheme, which is now been renamed GES. But the point was actually not to try and merge these two different systems, but rather to introduce a new set of explicit guarantees for all Chileans, right, based on, in a sense, citizenship, not based on making a contribution, but a set of universal explicit health guarantees. Initially 56 interventions. I've put currently 80. I think it might be slightly more now. Funding, at least initially, with a clear earmarked source, 1% coming from VAT. And it essentially had this equalizing, not completely equalizing, but it had an equalizing effect driven by equity concerns and sort of watering down this link between the contributions and the entitlements, the particular scheme that you were in. I'm sure you'll hear more about that in a lot more detail. I think it's a really nice illustration of an equity motivated policy decision around benefit design. On this slide, I just want to, I'm not going to read out all the text on it, but just looking at the title here, Thailand, and again, I know that's another of the case studies. It's a really interesting country, what they've done over the decades. Key message at the top, it's the supply of quality services which actually drives, in many respects, equity and service use. And this comes back to our, at the beginning, this thinking a little bit more broadly around benefit design and thinking about all public spending. So I think the key message here is, and what's very interesting is what Thailand did in the early 80s. And they essentially made a concerted effort to correct the imbalance in the supply of services between urban and rural, broadly speaking. And you can see that they froze all new capital investment in urban hospitals to build up rural district hospitals, combined, of course, with supply of the workers and the doctors, community health workers, some mandatory service in rural areas, but also good conditions, which also matters. So the compulsory placements written at the bottom there. So I think, you know, this is quite unusual, and this is what's also fed or enables this position that I referred to on the process slide, that the variability in service delivery matters and consideration of benefits, and that point I already made. If you can't deliver a new benefit to everyone in the country, then you don't approve it, not until that is ready. Really, I think, important lesson for many other countries. Right, let's have a look at what we got on this slide. Benefit choices. Are the wrong interventions being funded? So the chart on the left is taken from BMJ clinical evidence. It's a little bit old now. It's only done periodically, but it does reflect, reflects global practice, right? So it's not just higher income countries, for example. And it's basically looking at the clinical evidence that underpins services that are being funded in a number of countries around the world. Okay, the big standout is unknown clinical effectiveness, 50%, the left side of that pie chart. Not surprising, right? It's quite a job to, produce that evidence. Top right, 11% beneficial, 24% likely to be beneficial. Let's zoom in on the bottom, like 4, 5, 6 o'clock there, likely to be ineffective or harmful, 3%, unlikely to be beneficial, 5%, and another 7%, some trade-offs, around 15% there. And I'm not going to read the text out on the right, but this is what I'm speaking to. Essentially, the message here is that there's probably a lot of waste. There are probably a lot of publicly funded benefits which, in the worst case, may be harmful. And I know in my country, the National Audit Office actually periodically does an audit of these things and identifies services which are verging on harmful, or where there's very unproven, or there may be some proven clinical ineffectiveness, in fact. Now, this is the kind of information that has to be translated into policy, in particular where you've got a purchasing, an explicit benefit package, right? And ideally combine with that a strategic purchaser that can actually create these shifts and make sure that public spending is going as far as possible away from proven services that are proven to be ineffective clinically, excuse me. The unknown effectiveness, clearly there has to be some judgment there. You wouldn't just pull funding from all those. But I think, anyway, it's an important thing to think about, that this evidence, and again, that ties slide from earlier, that having a process that systematically looks at and actually demands the generation of such evidence is really important to make sure that we maximize benefits for scarce public resources. Another key system level consideration from the perspective of efficiency is whether or not services are being delivered in the right place. The chart here, I put this together from a time when I worked with the Philippine Health Insurance Agency, and I took information from the claims databases on the facilities in which treatment for diarrhea and community-acquired pneumonia were being reimbursed. These are two conditions which are primary care sensitive, i.e. they should be treatable and are treatable, should be managed at the primary care level. What you see on both those is that almost half in both cases of those conditions were being reimbursed for treatments in tertiary level hospitals. Extremely inefficient. Now, top right, clearly you need to investigate the underlying causes here, but it looks extremely inefficient. And again, coming back to benefit policy, it's not to say you don't treat diarrhea or you don't treat community-acquired pneumonia, but you use your condition of access, right, together with your purchasing to ensure that you're only reimbursing for services to be delivered in the appropriate facilities. Perfectly legitimate concern. Again, I think the ties stop funding cataract surgery in inpatient facilities because it is now available across the country in outpatient facilities. So you can link that with the work that's going on with clinical pathways, patient pathways, really important area of work for strategic thinking on benefit design and improving efficiency. Okay, I'm running out of time here, so let's talk about some comfortable truths or some hard talk, some hard questions? So there's 3 questions on this chart, which that particular publication, I've put the link there, put forward as saying these are unacceptable, which is a very strong term, but let me say inconsistent if you're really serious about progressing and shifting and driving health systems towards universal health coverage. And I put it up there, what is the reality in Egypt and other countries in the region? I'm not going to spend a lot of time on this, but for example, they propose it's unacceptable to expand coverage for low priority services before all citizens have access to high priority services. It's unacceptable to further benefit the better off before the worse off have good coverage, and so on. So I think some good sort of checks questions here to challenge us, and maybe you can take that forward at the end of this presentation in your groups. Thanks. And we'll just finish off with some key messages, and again, not going to read all these out, but what we've done in this particular document, the Health Financing Progress Matrix, is define what we think is good practice around benefit design. We've done it for other areas of health financing policy as well. We've defined these as desirable attributes of benefit design. There's 5 there. I leave them with you and with Ahmed and others to discuss. I'm afraid I'm covering a little bit at the bottom right. On number 5, benefit design includes explicit limits on user charges and protects access for vulnerable groups. I'll have to stop there. Thank you very much for your time. Sorry I can't be with you, but very happy to interact as best I can afterwards. Many thanks. Bye-bye.
Thank you very much, Dr. Matthew. And now we're gonna turn, we do have like a bunch of questions, but we're gonna hold till the end of the session. The presentation is really very insightful, but I think now we will turn to the Egyptian experience. I'm pleased to invite Dr. Ahmed Siam, the Deputy CEO for the Technical Affairs at the UHIA, to share Egypt's current approach and priorities regarding benefit package design under the UHIS. And I want to seize the opportunity and thank you for your support, your continuous support to make this webinar series launched. Thank you, Dr. Ahmed, and the floor is yours.
Well, actually, thank you, Reham and EIL and JPAL for your continuous support. And of course, our dear friends and colleagues at the WHO for supporting this. And of course, thanks to Dr. Emilio for taking the time to give us this presentation and share the experience from Chile in designing and implementing benefit packages. I'll try to be brief as much as I can. I don't want to waste your time on talking on what's already happening in Egypt. I know most of the attendees are already from Egypt, so they have some sort of idea on what's happening. So we want to keep as much time as possible for Dr. Emilio to deliver his presentation. If you can just give me 1 second to share the presentation. Okay, so hopefully everybody is seeing my screen clearly.
Yes, Dr. Ahmed.
Okay, so my presentation will be just a basic introduction about the UHIS and the Universal Health Insurance Authority and where we currently stand, and a quick overview on the challenges that we have which relate to benefit package design and implementation. So to start off, Egypt currently has a population of more than 107 million citizens. Our GDP per capita is currently 3,541. So this makes us a lower middle income country. And of this GDP, actually the public health expenditure represents only 4.74% of our GDP, which correlates to around 30% of the current health expenditures, while of course out-of-pocket spending is the leading source of financing health services in Egypt, with more than 60% of the current health expenditures. Egypt has also started on its agenda towards achieving universal health coverage, and we are committed to achieving universal health coverage hopefully by 2030 or 2032 to keep up with the SDG agenda. And consequently, the health sector in Egypt has been witnessing major reforms as of 2018 with the issuance of the Universal Health Insurance legislation, and which was also followed in the consequent years with other legislative amendments and other reforms as well. So currently, we are in the middle of a transitional phase in our health sector transformation. So the UHIS is being implemented gradually on a geographical basis. So currently, we have 5 governorates where the Universal Health Insurance Scheme is currently up and running, while the remaining governorates are still under the old setup and the old schemes, and are set to gradually join the Universal Health Insurance system. UHIA is set to be the main strategic purchaser for curative health services, mainly for the entire population, while preventive healthcare, health promotion, public health services, and emergency medical response, as well as infertility and family planning services, will still remain under the dominion of the Ministry of Health and Population. And this is actually a diagram that I like to borrow from my dear friend Ahmed Khalifa. It shows the current financing setup in Egypt. Of course, I don't want to go into the details, but as you can see, the middle area in the diagram has lots and lots of arrows and many intersections. We have multiple schemes with multiple payers and multiple providers. And this was actually why we started thinking of implementing universal health insurance to try to, as much as possible, consolidate this fragmentation in the healthcare system in Egypt. So basically, this is just a quick comparison between the universal health insurance and the old system. So in the old system, we had incomplete coverage that ranged to about 60% of the population. Coverage was guaranteed for specific population groups, like the public and formal sector employees, preschool children, school children, widowers of public sector and formal sector employees, as well as women in female-headed households. While in the universal health insurance scheme, we promise coverage for the entire population. In the old system, there were multiple fragmented fund pools, either in the health system in general or even within the HIO, which was the leading health financing agent in the old schemes. While, of course, in the universal health insurance, we're looking more towards a single fund pool for better pooling and better risk subsidization. In the old system, of course, the coverage was individual-based coverage. So if for example, as Ahmed said, if I'm a formal sector employee, I am granted coverage under the HIO, but my wife, for example, if she doesn't have work of her own, or if she's a stay-at-home mom, then she won't be benefiting from insurance coverage. Also, my children as well, if they are in the school, they are covered under the school children scheme, but once they graduate school and move to university, for example, they are not subject to coverage under the HIO. While, of course, the universal health insurance is a family-based coverage scheme, so we basically cover the entire family, and the head of the household who will be supposed to pay his contributions on behalf of himself as well as his family members as well. In the old system, we had an optional enrollment, and we also had an option to opt out from HIO coverage, while in the universal health insurance, it's a compulsory enrollment for the entire population with no option to opt out. In the old system, we had a provider-payer integration. So basically, the HIO was the payer responsible for collecting revenues, pooling these revenues, and it was also the provider. So it had its own healthcare facilities, whether hospitals or polyclinics, that they provided the service through them, and they also purchase healthcare services from other providers, but mainly in the public sector. For the universal health insurance scheme, there's a full provider-payer split. So the universal health insurance authority is basically the payer. It's the insurance company that's owned by the beneficiaries, let's say. And we strategically purchase healthcare services from public and private providers, and we pay for these services on an output basis, rather than the previous way of financing healthcare services through line item budgeting for public facilities. In the old system, of course, also beneficiaries were allocated to certain providers, mainly public providers, so they had very limited choice in choosing their providers, while in the universal health insurance, beneficiaries are free to choose between providers that are contracted with the Universal Health Insurance Authority. In the old system, we also had line item budgeting and input-based financing for healthcare providers. In the universal health insurance, UHIA is paying providers based on the services that they provide. In the old system, we also had a sort of passive purchasing and no defined benefit package, while in the new universal health insurance, we're looking more towards strategic purchasing of a well-defined explicit benefits package. And this is supposedly the new health financing setup and the financial flows. This is also borrowed from my dear friend Ahmed Khalifa. And as we can see in this diagram, actually most of the government, most of the revenues will be directed to the Universal Health Insurance Authority, and the Universal Health Insurance Authority will be purchasing healthcare services from all types of providers, whether public or private and NGO affiliated providers as well. And this is just an illustration of the entire health ecosystem. So basically, we have the three entities that were established under the UHI, the UHIA in the red box, the EHA as a main public provider with other providers in the purple box, and we have GAHAR, the accrediting body, in between. And we also have other government entities that are more or less participating in managing other parts of the ecosystem. So we have UPA, which is responsible for bulk procurement and managing the supply chain and the maintenance chain for public providers. And they also actually provide provide healthcare technologies to also private providers that are contracted with the UHIA. And we work actually with the UPA in the HTA and the part related to negotiating and commercial agreements for health technologies in general. We also have the Egyptian Drug Authority, which is the regulator for health technologies, and the Egyptian Health Council, which is the regulator for healthcare practitioners. And of course, we have the Ministry of Health as the super regulator and the coordinating body between all of the entities in the healthcare system, as well as retaining its function as the strategic purchaser for public health services, preventive care, and reproductive health services as well. And at the bottom, we have the Ministry of Finance, which is responsible for paying the subsidies for the poor and the vulnerable to the UHIA, and also transferring the earmark taxations that are part of our revenue structure. And also the Ministry of Finance provides temporary budget support to public providers on their path towards their own financial reform. So we don't cut funding immediately from public providers. We give them some grace period to adapt to the new type of payments and the new setup of the universal health insurance. So in the new system, of course, UHIA is a public authority. We are responsible for managing and financing the universal health insurance scheme, and we aim at extending healthcare coverage to the entire population. Our main roles at the UHIA include revenue collection, pooling, purchasing of healthcare services, which includes benefit package design, costing and pricing of services. We also are responsible for provider contracting, following up on the services that are provided to our beneficiaries, and of course, managing the claims submitted from providers for the services they provide to our beneficiaries. And we are also responsible for developing, managing, and maintaining the IT ecosystem. And we actually have a very, very ambitious digital transformation strategy, trying to make all the insurance-related transactions as seamless and as efficient as possible. As for the revenue sources for the Universal Health Insurance Authority, so of course we have three main categories of revenue sources. The first category is the premiums, the contributions, and the co-payments. The other main revenue source is some earmarked taxation and some fees, like the corporate social solidarity contribution. We have earmarked taxation levied on cigarettes and tobacco products, some fees on toll stations in highways, and on issuance and renewal of motor vehicle and driver's licenses as well. And the third component is the subsidy that is paid through the National Treasury for the vulnerable population groups. So basically, the UHIA is tasked with identifying the poor and the vulnerable, and then we send this data to the Ministry of Finance, and the Ministry of Finance will be paying the contributions of these vulnerable population groups. And the last source of financing is actually the investment of UHIA surpluses and our retained earnings. And actually, the UHIA currently we have a very big investment portfolio, and we're looking to actually develop this investment portfolio to help us with managing the sustainability of the Universal Health Insurance Scheme as we gradually expand to more and more governorates and provide coverage for more and more beneficiaries. And this is the current status. So currently we are operational in 5 governorates. We started with the Port Said, followed by Luxor, Ismailia, South Sinai, and finally Suez, which is the last governorate to join the scheme earlier this year. We have only one more governorate left in the phase 1 governorates, which is Aswan, and hopefully we will be also formally launching in Aswan by the end of this fiscal year or the beginning of the new fiscal year. We currently have 3.75 million beneficiaries. Our average enrollment rates in the 5 governorates is 82%. It ranges actually between 80 and 92%, depending on the governorate and the maturity level within each governorate. Our current provider network currently has 373 providers, of which 24% of these providers are actually from the private sector. As for the strategic purchasing, so basically purchasing usually refers to the process by which the funds are allocated to healthcare providers from the payer or the financing agent in order to obtain services for the identified population groups, the beneficiaries of, in our case, the Universal Health Insurance Scheme. Therefore, purchasing is always viewed as the critical link between the resources that are mobilized for universal health coverage and the effective delivery of quality healthcare services. And strategic purchasing is one of the most important tools that we use actually to regulate effective service delivery and quality healthcare. For purchasing, there are 2 main types of purchasing. Of course, passive purchasing, which was the norm in the previous era, which basically implies just following like a predetermined budget or having a payer that simply pays bills when presented. without any review or look into the medical necessity, appropriateness, etc. While in strategic purchasing, we continuously search for the best ways to maximize health system performance, using our main strategic purchasing tools, which are the key decisions that are taken by the payer, which interventions should be purchased, how should these interventions be purchased, and from whom are we purchasing these interventions. So purchasing involves three main sets of decisions. The first one is identifying the interventions and the services to be purchased, which is the benefit design. And this is the core of today's webinar. And in defining benefits and entitlements, we should always look into population needs, our national health priorities, as well as the cost effectiveness of these services and interventions and their budget impact as well. The second set of decisions would be related to choosing service providers, and usually we give consideration to the service quality, the efficiency, as well as the location of these providers to ensure equitable access and availability of healthcare services to the population that we actually serve. And the third set of decisions are related to determining how these services are being purchased. So this includes the contractual arrangements, the pricing negotiations, the development of provider payment mechanisms, as well as the rules that govern the entitlement to services under the universal health insurance. So in order for us to become a strategic purchaser, there has to be some conditions, let's say. First of all, you have to have a very clear benefit package and service quality standards. The payer should actually move from the role of being a price and quality taker towards a more active role of being a price and quality maker. So this involves selective contracting with providers based on the quality of their services, their efficiency, the accessibility of these providers, as well as using output-based payments and deliberate incentives like different provider payment mechanisms and the payment rates as a tool to actually incentivize healthcare providers to provide healthcare services as per the needed level of quality. As well as, of course, there has to be continuous monitoring and accountability of the providers on the services that they provide, as well as actually accountability between the payer and the beneficiaries that we serve in terms of how decisions are being made, and the transparency and the clarity and communicating these decisions to our beneficiaries so that they can be actually updated and knowing how decisions are being made and why specific decisions are being taken. Now to move to the part related to the benefit package. So as we all know, the benefit package is not just a list of services. It's an entire ecosystem, if we may describe it. And it has three main components. First of all, it has the governance framework, which includes the governance bodies that are responsible for making a benefit package inclusion or exclusion decisions, and the decision frameworks and criteria that govern the function of these governance bodies. And of course, these decision frameworks and criteria should be set to actually serve the national health goals and our transformation agenda. So this is the decision-making part. In order for these governance bodies to be able to make a decision, then there are evidence synthesis processes that feed into this governance process. So this includes of course, the organizational structures and policies and SOPs that are used for health technology assessment, for example, as well as the guidelines, the templates, and the capacities and the people who are actually working to synthesize evidence for the decision-making bodies to be able to make their decision based on evidence and have informed decisions for inclusion in the benefit package. And then you have the benefit package itself, which also has multiple components. So first of all, you have a high level table of benefits and general exclusions. Then you have the detailed lists of the services that are and the interventions that are covered within the benefit package. And of course, the manuals and the guidance that is issued by the payer to govern the services that are included in the benefit package. And this includes the medical rules, the reimbursement rules, as our dear colleague Matthew Jowett explained in his presentation. So for the current status, UHIA has already started its journey in benefit package design, as well as other strategic purchasing activities like the costing and pricing and development of the provider payments. What we have achieved currently is we already have a defined table of benefits. We have a fully explicit primary care benefits package, and we have a full sorry, and we have a full fee schedule and the service list for all of the services that are covered under the universal health insurance. And we have already also defined the provider payment mechanism for each type of service that is covered under the universal health insurance. We also have a full-fledged drug formulary and a prosthetic devices formulary, and we're actually currently working on building or completing the remaining formularies in terms of other medical devices, consumables, etc. So this is still a work in progress, and we're also working on developing what has actually been already there. The formulary, for example, we finished phase 1 and we're working on the phase 2. So we have lots and lots on our hands at the Universal Health Insurance. What's still missing is actually the structuring of the benefit package. So grouping the benefit package into different benefits and sub-benefits and linking these benefits together, as well as defining the benefit limits and the entitlements and the rules, whether they are reimbursement rules, eligibility criteria, and the whole package of guidance that is provided to providers in order for them to be able to know what exactly is being covered and the rules that cover this service provision. And then we also have another task of mapping these services to their service delivery levels, HCP credentials. It's been partially completed actually. So we have many of the services like the drug formulary, for example, each and every medication is linked to his appropriate provider level. We have the same for surgical interventions, for example, etc. And we're continuing to build more and more of these rules and this guidance. And also, we're working on mapping the benefits and the services to their appropriate resource utilization and taking this forward as part of our costing and pricing activities. But of course, we have challenges. One of the main challenges is that actually we are currently in the middle of a transition. So we have two health systems running in parallel in different governorates. And as part of also the transformation, we have 6 newly established government entities, whether the 3 UHIA entities or the EDA, UPA, and the Egyptian Health Council. And all of these entities are actually relatively new, and there's a little bit of misalignment on the or lack of clarity on the roles and responsibilities of each of these entities, and a little bit of a lack of coordination between different stakeholders. And this is something we are actively working on with all our partners in the government. Another challenge is that we don't have a nationally adopted benefit package or a set of clinical practice guidelines, and we have huge disparities between the standards of care between different schemes. So what's covered under the UHI scheme is completely different than what's covered by the old HIO or the patient treatment at the expense of the state, etc. We don't actually at the UHIA, we don't have developed yet a clear decision framework and criteria for benefit package inclusion and exclusion. And also another challenge is that the financing and delivery model for preventive services and public health services, and basically services that are not under UHI coverage, there's still a degree of ambiguity, and the financing and delivery model and the purchasing arrangements for these services are still under debate between the Ministry of Health and EHA, for example, which is the main public provider. As for the next steps, we split them into two, actually a group of system-level interventions that require collaboration and joint work between the different government stakeholders. These include, of course, working on aligning the roles and the responsibilities and the functions and the segregation of functions between different government entities. Developing a national framework to govern the benefit package design and review, including, of course, the evidence-based criteria. Developing nationally adopted clinical practice guidelines, and we're looking for an inclusive process that has involvement for all of the stakeholders in developing these guidelines, as well as input, of course, from providers, from patients, and from the payer as well, because there is an economic component to developing any kind of guidelines or protocols. And we're also working in collaboration with the UPA and the EDA on establishing a unified national HTA process to help on evidence synthesis and advice on adoption of new and innovative healthcare technologies within the publicly funded healthcare services. The second set of interventions are mainly UHIA level interventions. So this includes revising the current structure and the mandates of our main governing committees in the UHIA, establishing the Health Economics and Health Systems Research Department, which I proudly lead currently. And of course, capacity building for our staff at the Health Economics and Health Systems Research Department to equip them with the necessary knowledge and tools to be able to effectively support decision making, especially, of course, in the benefit package inclusion. And we're also working on a full review of the current benefit package, which includes categorization and grouping of these benefit packages, as I said previously, defining the benefit limits and entitlements that haven't been defined yet, developing disease-based guidance, completing the service lists that are still under development, and developing the auto adjudication rules and the medical rules and the mapping between services provided versus the appropriate diagnoses, medical specialties, service delivery levels, healthcare practitioner credentials, and coming up with a full medical rules dictionary that will, of course, be uploaded to our CCE or the medical rule engine that is responsible for claims auto adjudication. So this brings me to the end of my presentation. I thank you for listening, and of course, if there are any questions, I would be happy to take any questions in the Q&A session at the end, inshallah. So
Thank
thank
you,
you.
Dr. Siam.
Back to you, Reham.
Thank you, Dr. Siam. Definitely, all of us, we do have like a bunch of questions for you. We thank you very much for giving us an overview on the new system and do this comparison between the old and the new one. I really appreciate shedding the light on the gaps and the challenges that the new system is currently facing. And this is actually let us pave the way to the Dr. Santelisa's intervention, the former Minister of Health in Chile. Dr. Santelises will share the Chile's journey in developing and adopting benefit packages under the universal health coverage, along with key lessons that may be relevant to the Egypt context. Dr. Santelises, the floor is yours. We are on fire to hear your journey.
Hi, good afternoon. I need that Hamed take out your presentation, please.
Great.
I stopped sharing, so
yes.
you can.
Dr. Santelises, you can share your presentation now.
Yeah, I was waiting that the presentation to take out the.
Okay.
Okay. Do you see fine?
Esther, we are waiting. Now it's clear. It appeared.
Oh, perfect. Thank you. Thank you for your invitation. It's a pleasure to me comment about the experience that you develop in Chile during the last 20 years in relation with the universal coverage and the package of the universal system. I'm talking from Santiago, Chile. You can see there the mountain Los Andes, and this is I will be very, very happy if you can visit our country in the future. So let me. I don't know why I can't to move the.
You can. If we have the presentation, Yaro, we can share it from our side and just mention, yani just call us when you want to skip the slide. If there is something, if you can do it from your side.
I'm happy to share it. Let me know, Dr. Santelises, if you would like me to share the presentation from my side.
Let me check. I'm not sure because.
Wait.
Oops.
Yes, it's clear now for us.
Now?
Now it's clear.
Okay.
Yes.
Yes.
Perfect.
Okay. So I like to today. I like to talk about what is the reason, because we need to talk about the universal coverage and how we develop an explicit health guarantees. How has been the experience of Chile? The first step is to recognize as the situation of the most part of the countries. Here I show you how has been the reality of Chile. You can see here how has been the development of the budget and the general budget, and how has been the relationship between the budget, the national budget, the income, and the health cost of health. You can see that during the different years, each year, the relationship between the variation of the GDP with the health spending is the 3.5 times. That means that all year, you need more money for give a solution for the health for the people. So the challenge for everybody is how we can decide what the benefit you can do in relation with the financial situation. And that's the reason, because appears around the world the necessity to talk about the universal coverage. What does mean the universal coverage? At least we need to establish 3 dimensions in relation with that. One of them is what portion of the costs are covered. The second step is which benefits are covered, and the third line is who is insured. So when you establish the answers for these 3 questions, you can establish what will be the package that you can design for your population. How was the situation that we established in Chile 20 years ago when we built the public policy in order to establish the guarantees? And the main issue that we include in this kind of the public policies was to access opportunity, financial protection, and quality. So in summary, in relation with access, the law established the obligation of the insurance, public and private, to provide health benefits. In order to opportunity, we established the deadline for delivering guarantees benefits. That means that the people that suffered, for example, one myocardial infarction, they need to receive at least before the 2 hours, the first diagnosis. Financial protection means to what is the level of the copayment that they established by law. And the fourth dimension is the quality. We need to establish that in relation with each one of the guarantees, you need to establish the provided, accredited by the quality. And in summary, today we had 87. Here I show you only the 80, but the 87 problems of health. And each one of the problems include the prevention, diagnosis, treatment, and control. So the Ministry of Health established the frameworks for the law 1966, that explicit health guarantees. And by different decrees, but different years, in the first step with 25 guarantees, until today are 85 guarantees. We establish a new guarantee each 3 years. In summary, today, how you said before, we have 87 problems of health included in the package of the guarantees. And until today, we have a service to 3.6 million of the population in the public insurance, and we have provided the attention to 163 patients for the ISAPRES. ISAPRES means the private insurance. The total the population that received the benefit has been until today 3.7 million of people with different problem of health, diagnosis, treatment, medical treatment, surgical treatment, etc. And how we establish the prioritization? That is very, very important, because how you comment before is very, very important to establish the appropriate intervention in order to establish the equitable financial efficiency and transparency in relation with what kind of the service you provide to the population. And the criteria, how we establish what kind of the disease you include in the package are: first, disease burden criteria; the second, evidence of the benefits to survival and quality of life; the third is alignment with the country health objective; and the fourth criteria is relation with the cost and supplier capacity of the public and private sector. In relation with the comment that said before Hamed Rayan, in relation with the rare disease are not included in the package of the guarantee because we have other additional law that's named Ricarte Soto, is the law that protects with the people through the specific rare disease, because the rare disease have other kind of the criteria in relation with the prevalence, the survival, and in relation with the cost that they have this group of the disease. I think that it's very important to establish that the package of the benefits need to establish for the most common disease of the population. And who is the people that establish the group of the disease? In our case, we work very joined with the scientific society through the Ministry of Health, invite to different specialists of the different disciplines, surgery, medical, cancer, etc., and invite them to establish the little committee with the authority of the minister, and all together establish the specific package for each one of the disease, and establish in a specific board how these criteria prevalence to the first, second, third, and the different disease that include each 3 years. And in summary, we have coverage, and the package includes emergency cares, some kind of specific area, trauma, for example, surgical intervention, gallbladder, each one of them, rehabilitation, non-communicable disease, cancer treatment. In cancer treatment, we have 14 cancer. The most important cancer, more or less 85% of the cancer are included into the guarantees. Ophthalmology disease, neonatology, communicable disease, how we have VIH, labor, respiratory disease, mental health, traumatology problem, another oral problem included. That the total summary 87 problem of health. That means that today, through this package, we give the coverage to at least the 80% of the prevalence problem of disease population. For example, how we design one specific package. Here I show you the diabetes mellitus. Diabetes mellitus have a high prevalence in Chile, and the guarantees of access includes when you have the patient with suspicion, have access to diagnosis, confirmation of diagnosis, and including treatment for diabetic food, included treatment for the descompensation, and include treatment for the other situation in relation with the kidney disease, eye disease, etc. In relation with the opportunity, the law specific establish how long you have in order to give the treatment and diagnosis to the patient. For example, consultation with the specialist will be conducted between 7 days of appears the doubt in relation with the abnormal blood test. That means that, for example, the general physician recognize that the patient have an blood sugar higher, they need to send to the specialist, and they need to receive the diagnosis at least in 7 days maximum. And in relation with the opportunity of the treatment, they need to begin the treatment in 24 hours after the diagnosis have the confirmation. And the people have the this compensation, they have they receive the treatment at least in 30 minutes in the emergency department. That is very, very specific how the decrease established how the patient can to have the guarantees of the opportunity. And finally, in relation with the financial protection, here I only show the part of the financial protection, for example, and a specific and a diagnosis. When appears the patient confirmation with the diagnosis, the periodicity is every time, and you have a specific price, and you have a specific copayment. The copayment for the patient is 20%. And on the other hand, for example, in relation with the treatment, we have a specific treatment each month and with a specific price. And you recognize that in relation with this price, the copayment is 20%. And all the patients know how much they need to pay for have the guarantees in the access and the treatment. And appears the financial protection and specific for each one of the prescription that you receive from the medical. And how has been after the 20 years that we established this this law, and we include each 3 years different disease. And I like to show you how we identify the result. For example, the great burning, we recognize that the decrease and very significant decrease of the fatality situation between the 70% to 31%, and the survival rate increased from around the 50% and 70% in 5 years. The reason why appears this nice result, because the patient have the opportunity, and the different provide by law have the obligation to give the treatment that have a specific prescription and a specific coverage in independently of the capacity and independently of the patient is coming from the private system or if he's coming from the public system. And the breast cancer, for example, that we have, but the breast cancer, we have a decrease of the mortality adjusted by analyzing the survival rate, after the implementation of the guarantees, appears that the breast cancer increased the survival 1%. And in relation with gallbladder cancer, for example, we have again a decrease of the mortality after the period that appears the guarantee of the coverage for the gallbladder cancer. And the same situation with acute myocardial infarction, that the mortality fell from about 14% to 70% through the only 7 years. And the survival increased from 93 and 97%. Has been very, very significant, because the treatment of the cancer include the coronariography, included the angioplasty, and include the surgery. And BHH, the access improved. All people with the diagnosis at the total 100% the coverage of the treatment, and the survival rate increased from 85% to 93%, and only in 5 years. When you ask the question to the population, and in the score between 1 to 7, the most part of the population have a high record and recognized in relation with this public policy. The most part of the population put the score over the 5 or 6, include the 7 record for the record. That means that recognize the grateful and what that means for them, this kind of the law. In addition to identify how we recognize the protocol, how we establish the package, and we establish the guarantees, we establish the structures around the law. That structure include the National Register of the Individual Health Providers. That means the superintendents of health show to the citizen and show them and made available for them the individual health providers. That means that the people have to the access to give this kind of treatment, have the register as specialists and the qualified condition in order to save to the people that the professionals that give the treatment are under control and have the different register qualified condition for each one of the specialties. Include the hospital, the primary care, the lab, the imaging center. Every provider have the register and the superintendencies in order to give the treatment to the patient that want to receive the treatment by law UHIS. In addition to this kind of the structure, each one of the disease have a specific guideline that describe how is the route of the patient, how is the different step by step in order to give the guarantee of the quality and the opportunity of the service has been done perfect for everybody. So this kind of guideline are developed in together with the professional team coming from the different medical and scientific society. So they have been very, very significant support to the develop of this law for every year. And in addition, we established the national network of the providers, and you can identify in each area, in each area of the country, what is the kind of the hospital, public and private, that have registered in the national register from the for the specific attention for each one of the conditions that are included in the law. So each one of the establishment provider need to maintain a control of quality that is registered in the superintendencies of health. And all of the framework that include the protocol, the guidelines, the result of the patient has been supported by the network, technology network, that help to everybody to maintain the register of the disease, maintain the register of the result, and the different complications that you can to identify during the process that receive each one of the patient. What is the next challenge for the future? At least the main is improve the explicit health guarantee in accordance with the new technology. How you know each one appears new technology. The committee that are in the monitoring of the different protocol recognize when appears the new technology and discuss the cost effectivity of this new technology, and they propose for the next decrease in the next 3 years. They propose if they change the protocol. So that means that, for example, in the cancer, appears new drugs and new technology very, very fast. And so it's very important to identify if it's necessary to change the original protocol in order to guarantee to the people that they receive the most, the best treatment relation with the cost effectivity and related with the evidence. The second challenge is expanding the financial coverage for medicine and supply in context of rational use, of course. And the third challenge is the efficient purchasing mechanism. In relation with that, in Chile, we are working very, very strong from the 10 years ago, using the pay for performance, and in specific, we are using the DRGs. And for many conditions, we establish the mechanisms of payment that include the DRG system in order to adjust the risk to the pay between the insurance company and the providers. And the fourth is promote and improve the research and monitoring of the explicit guarantee. It's very, very important to develop new tools in order to analyze how has been the development of the guarantee through the years. Introduce the regulatory change to optimize the financial system, develop a study, improve process and facility change basis of the new technology. And the other issue that for us is very important for the future is incorporate the citizen participation in prioritization. Because during the first time, this kind of prioritization was doing between the authority and the specialties. And today we have developed a very, very interesting experience. We include, in the case of the other law, the law that the rare disease that include the citizen in order to establish the prioritization. And maybe in the future, through this kind of experience, we can include the citizen to establish the next step for the include other disease. And the other issue that is very important is, the challenge for the future is to put the guarantee, how you name it, HIS, guarantee explicit of health, is in Spanish, the HIS in the population to establish the communication campaign. In summary, the WHIS encouraged the country to move toward universal health coverage. This must be done based on the financial capability of each economy. Of course, in the case of the Egypt, it's different to Chile and different other country. Each one need to establish steps by step, but under the main issue that we comment during this morning, that include the equitable, financial, and efficiency and transparency. And of course, it's a very, very important challenge that we need to continue introducing in our country for the future. We need to continue with the prioritization, because of course we don't have total the money that we need for the total that required. and developed countries must increase their public spending of health. And the key to success are determined by the ability to design and implement the good public policy and the ability to rapidly assimilate new ways to achieve access to health. Thank you so much. I hope that the respond the question that you have in relation with the experience to Chile.
Thank you very much, Dr. Santelises. It was really very insightful. A bunch of a bunch of information actually can help the UHIA focal points to build the benefit package. I think for the time, and I know that we do have like a bunch of guests that want to ask a question. I'm going to leave the floor to my colleague Dr. Ahmed Khalifa for moderating the open discussion.
Thank you
Ahmed,
very much.
Yours, okay.
Yeah, can you hear me? Yes. Thank you very much, Riham, for this, and I'd like to sincerely thank, of course, Dr. Santelises for his presentation, and also Dr. Ahmed and Matthew. I think there has been a lot of learnings for us in Egypt, and I think before we open the floor for questions, one of the common theme across, particularly with the Chile example, but across all presentations and even with the opening remarks, is that now we recognize that the benefit package is more than just a list of services. What's particular about the Chilean example is that it has explicit guarantees for conditions of access. In this case, the 4 conditions that the obligation to access, whether in public or private, according to the enrollment status, the timelines associated with each service. Dr. Emilio mentioned the 7 days, for example, for certain conditions, etc. It's very, very specific, and also very specific financial protection rules and quality rules. I think now we can have a discussion around the key questions from the audience. If you'd like to ask a question in Arabic or English, that's fine. You just raise your hand or you write in the chat box. We have maybe 10 minutes of open discussion. Probably if until someone raises his or her hand, I'd like to direct my first question to Dr. Santelises on your presentation. It's very, clear and elaborate about the criteria to decide on the benefit package and the room for update every 3 years, which is very important. That it's not a package set in stone; it's a dynamic process. But I'd like to hear more on the representation of the committee that decides on the selection of the package. You mentioned that the Ministry of Health is the convener, and you rely on scientific communities. But does it have SOPs, standard operating procedures? How many members? Does it have people from civil society? Does it have patient representation groups, etc.? So I'd like to hear more about that.
Yeah. When we start with the implementation of the law, the Ministry of Health called through the one commission to different scientific society with the specific problem, and the different scientific society send the representative professor of the specific area, in order 5 or 6 of them of different hospital, and they work through one specific tool, one specific question, and design how they respond the main issue. What will be the exam that they need to include after what has been the treatment, and in relation with the treatment, they work together with the economic committee and the medicine evidence that show them that has been the principal choose in order to cost-effective decision. And they established a very intensive discussion in different disease for establish what is the best treatment for the population for the specific disease. I think that has been one of the key route in order to recognize the main treatment. Of course, in this kind of the discussion appears some guy that said that, come on, you are include only one or two blah 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 treatment. It not include others, but of course, because we need to think about how we establish the cost effective in order to the most part of population have access to the treatment. So, for example, if you a doctor recommend other things out of the guarantee, the people is free, can you choose, but they don't receive the financial protection.
Okay, this is well noted, I see. I think also one of the key differences between the health system in Chile and in Egypt is that, as I understand from your presentation, the committee decides which are the important conditions or diseases first. So I decide on 25, 50, until it reached now 87. The difference with Egypt probably, and I bring this to the attention of all audience and then also to hear from them, is that a starting point in the Universal Health Insurance Law is that all diseases are covered, but we're only allowed to choose between specific services for these diseases. So we cannot, for example, say that one disease is rare or is not affecting a big population group, so that will not be covered. But we can say that we can cover only symptomatic treatment, for example, but not the non-cost effective treatments. So I think we have one question from Wala. She's asking about the two systems in Chile, the public and the private, and how different they are in terms of the services provided and the amount of co-payment paid for these services. I think you highlighted this during your presentation, but if you can also reiterate this one more time.
Yes, how we define by law the treatment and the co-payment by law independently if the people is coming from the private or the insurance or the public coverage. Everybody, the universal is a universal law, of course, need receive the same treatment and the same protocol, and independently of the condition of the patient, independent of the financial protection, for this kind of specific group, 87 group, the insurance company, the private insurance company, established a specific relationship with different providers and send to them this kind of the providers, the patient they need receive the treatment by HIS. So the insurance company, in the case of the private system, the insurance company established, for example, for the gastric cancer, established the relation with the specific hospital that established the price with them, and the patient pay only the co-payment that describe the law, and the price is determined for the guarantees. So they can to pay more than the guarantee established. So for everybody, the same treatment and the same coverage financial coverage.
Yes, thank you very much. So I think now we're about to. Okay, one last question. Oh, that's from him. Okay, so Braham is asking about the national registration of patients and providers in Chile and how.
If you want, I can.
Please.
If I want, I can. Santelices, you mentioned, in your presentation, you talked about the national register for individuals and health providers. I would like to know more about how you built this and from where the data comes from. And I would love also as well to know from Dr. Siam if Egypt has also a national register for the new health insurance system or not.
We have one institution that named the Superintendents of Health, and the Superintendent of Health have one of the obligation is to establish if each one of the physician have the certification of this organization. So, for example, if you finish my study has the cardiology, I need to send to the certify to the superintendents with more all the information about the university, and they keep the register has the cardiology, and I have the number there. So everybody, if you can open the web page of the superintendents, you can name it. For example, I like to know if the Emilio Santelices is cardiology, and you can to look for there, and I need to appear there. If it don't appear there, I can to give the service as the cardiologist. It's illegal. In addition, the superintendent have the register of each one of the institution, and each 2 years the institution give the exam for the maintain the official register as the official provider of the guarantees. So it's very, very close to the Joint Commission, but the Chilean Commission. The Chilean Commission established the standard of care, standard of quality of each one of the institutions. So we have 2 register, or the individual register of the professional and the institutional register. Is official, is transparency, and you can see in the web page of the institution.
One more question, actually, it's something that is related to the welcome remarks of Dr. May and also the presentation of Dr. Siam. Both of them, they mention one of the challenges they're facing the health insurance in Egypt is the financial sustainability. I would love to know more how this actually how you maneuver this a challenge in the Chile's case. Santelices, over to you.
Okay. Sorry, but I didn't understand.
You didn't hear it? Yes. One of the points that have been raised by my colleagues from the Universal Health Insurance, Dr. Ahmed and Dr. May, that they're really one of the challenges that facing the new health insurance in Egypt is the financial sustainability. So I would love to know how Chile maneuver this and apply the universal health insurance for all.
One of the main issue for the sustainability of the system is in relation with the efficiencies of the providers. So one of the efficiency of the provider. The second is the new relationship between the insurance and the providers. I think that we need to advance in order to establish new mechanism of payment. I think that is the key route for the future in relation with the mechanisms of treatment. I think that I work a lot of time with the government of the Presidente Piñera. I planning and implement the mechanism of payment through the DRG with the payment adjustment risk. So these kinds of mechanisms avoid to establish the fee for service. That is very, very inflationary, and you adjust it to risk, and you establish the equity between the insurance and the providers. So this is the second step, and the third is in relation how you put more energy in the primary care. I think that we need to work more strong in order to the prevention, to avoid that the people develop the obesity, develop diabetes, develop and good control of the hypertension. And each one of the activity, you need a control in the primary level. How we saw before during the morning or during the afternoon, in your case, you have in one of the screen, 47% of the activity of the patient was developing the tertiary level. That is no good. You need to translate the most part of the attention to the primary care level. So that is the key. Standardization, protocol, guidelines. The second, new mechanisms of payment. The third, increase the result for health. And the fourth, the primary care level.
Thank you, Dr. Santelises. Ahmed, back to you.
Reham, I don't think we have more questions. Probably if before giving the floor back to you, I think I can just borrow from what Ahmed Siam has mentioned in his presentation, like what could be actions and next steps in the future. I mean, for us to learn from Chile, we have some foundation work to do. First is the mapping of the stakeholders that can undertake these functions and to assess the governance gaps that are available. That was mentioned in Dr. Ahmed's presentation. And from there, we can then start identifying the criteria for selection of services and conditions of access, and also to decide on the prioritization process in a transparent manner as much as possible, as for example, Chile is doing and other countries are doing. And then to find somehow between the existing legal mandates, how whatever committee that would decide on the selection of the package would have this advisory role or a legally binding role to have these decisions implemented. Very, very much useful session from all speakers, and I'll stop here and give it back to you for closing.
Thank you, Dr. Khalifa. Thank you to all our speakers and participants for such an insightful session. The discussion provided concrete insights into how international experiences, especially Chile's case, can inform Egypt's ongoing work on benefit package design under the UHIS. I also deeply thank Dr. Khalifa for summarizing the main points on the session and jumping into the next steps, something that I want to add to the floor as well. And this is something that has been already highlighted from different speakers, either at the WHO or even Santelises and Dr. Mayo, Dr. Siam. How can we use evidence and leverage the data to scale up proven intervention or scale back the inappropriate interventions? We see this is really very important, and it has been highlighted as well in the presentation done by Dr. Santelises. This is the first of 4 webinars in the Knowledge Exchange webinar series, namely Bridging Health Systems. The future sessions will cover different topics. The second session will still focus on the benefit package design, but in this case, we will highlight the Thailand experience, and we are working closely now with JPAL Southeast Asia for preparing for this session. Also, another session will be focusing on primary healthcare contracting. Well, this is another topic that has been highlighted by Dr. Siam in his presentation. That one of the challenges facing adopting the UHIS system in Egypt. And finally, the final webinar will be focusing on informal worker inclusion in health insurance. Our next webinar is going to be scheduled in 2 months, and the invitations will be shared soon. Also, a recording of today's webinar, along with a brief summary of key insights in English and in Arabic, will be also shared with all the attendees to support the broader learning. Thank you again for your engagement, and we are looking forward to see you in the upcoming sessions. Again, thanks for the JPAL Latin America for the support that they give us in order to be communicated with Dr. Santelises. Thank you very much, Dr. Santelises, for your insightful presentation and your time. Thank you very much.
Thank you.
Bye-bye.